Welcome to Primal Edge Health. Cutting-edge holistic lifestyle optimization with a focus on nutrition, environment, light, movement, and worldview. Exploring animal-based nutrition, whole unrefined ancestral foods, regenerative agriculture, homesteading, and a holistic lifestyle approach for health, vitality, and optimal performance so we can thrive and bring others along for the ride. Building healthy bodies, homes, families, and communities. Because we are far more than what we eat. Today's episode is brought to you in part by Ancestral Supplements, putting back in what the modern world has left out. Ancestral Supplements brings you nose-to-tail organ meats like liver, kidney, pancreas, brain, marrow, heart, thymus, thyroid, and more in simple, convenient gel and capsules. Order yours today at ancestralsupplements.com. Now let's get into the meat of this episode of Primal Edge Health. All right, I'm here with Dr. Bret Scher. He's a cardiologist. He runs Low-Carb Cardiologist.com. And I really appreciate you coming on. Really excited to talk to you about cholesterol, heart health, low carbohydrate diets, and what it is you're doing out there. So how's it going today?
Oh, it's going great, Tristan. Thanks for having me. I'm looking forward to the conversation.
Right on, right on. So what got you interested in a low-carb diet, being a cardiologist? I mean, you don't hear about too many low-carb cardiologists out there. We've got some celebrity plant-based cardiologists in these spaces, and they make a lot of noise, and they get a lot of attention.
Sure.
How did you
get that's the traditional teaching. I mean, low-fat is the traditional teaching for heart health. And, you know, in med school, residency, my preventive cardiology fellowship, that's what I was taught and that's what I believed, you know, and the problem is it's taught as if it's settled science, you know, it's taught as if there's really no debate. And as I got into my cardiology practice and I just kind of didn't see people getting better the way I thought they would. I wasn't having the impact I thought I was going to have on people. And a lot of it was patient noncompliance, right? The patients are struggling to maintain the lifestyle that you're telling them to do. And as I started to get a little more and more frustrated, am I just too naive? Was I just expecting to do more than I really could? I decided to branch out a little bit and start my own wellness center with a friend of mine who's a health coach and great guy, you know, super charismatic, super smart, works great with people. And I thought, okay, this is how we're going to have the biggest impact, to be able to work one-on-one, take more time and really get into people's life and their lifestyles. Well, we had a couple challenging patients, as you always do, that weren't really getting better. And he turned to me and he said, hey, we should try a ketogenic diet on this guy. So he had already known about ketogenic diets. He'd already had experience with them, but it wasn't a keto clinic. It was just a sort of a regular preventive medicine clinic. And I looked at him, I'm like, I'm a cardiologist. Are you crazy? I don't want to kill these people. I want to help them, right? Because that's what I had been taught. And he looked at me and he said, have you actually looked into the research on it? Have you read about it? And I said, actually, no, to be honest, I haven't. I'm just sort of regurgitating what I've been taught. So that started me on the whole process, right? Then I read, you know, Gary Taubes' Good Calories, Bad Calories, and that opened up this whole world. And so started looking at research. And that's what really blew my mind when I started looking at the research and actually saw that there were research papers published on it, whether it was Westman or Finney and Volek or, you know, some of the old timers, Yancey, I don't want to call them old timers, but the people, the pioneers, I should say, that there was actually decent research on this. And I just like, wow, why wasn't I taught this before? So we started implementing it with our patients. We started seeing impressive results. And I kind of ran with it because once you see that, you can't unsee it. And, you know, it's done a couple things. It's really revitalized my practice and the impact I can have on people has dramatically shifted. But also, it's really awoken me to understanding the difference in evidence, the levels of evidence. And that's another thing that unfortunately either we weren't taught or I didn't pay enough attention to, but you don't hear it talked about. Just evidence is evidence. Evidence-based is evidence-based.
Yeah, you just claim something's evidence-based and they're, well, all the evidence points to, and then you say whatever nonsense you want, and a lot of people will believe it, unfortunately, and they don't really know how.
Sure.
A lot of us, the critical thinking skills seem to be getting lower and lower as the attention spans get shorter and shorter, unfortunately.
Right. So understanding the hierarchy of evidence is so important. And that's something, I'm the medical director for dietdoctor.com now. Mm-hmm. And one of our biggest pushes right now is to really solidly evidence-based everything, not to just say it's evidence-based because we referred to some study that involved 5 patients and lasted 3 weeks, but to actually look into the evidence, rate the evidence in terms of its quality. If it's, data mining, observational study with a terrible hazard ratio, which really is not good evidence, versus a systematic review of randomized controlled trials, those are 2 completely different things. And so when we're talking about evidence basing, when anybody's talking about evidence basing, you have to differentiate between those 2 things. So sorry, you asked me how I got started and I went down this tangent.
No, I love it. I love it because this is exciting because, a lot of what we talk about here is the shoddy approach that people take to packing through the evidence. And, you see a lot of debates online where it's just, sometimes I completely disagree with both sides, right? Even though I, tend to enjoy a low carbohydrate diet and I see people benefiting from it all the time. I use it in coaching as, it's one of my favorite tools to implement with people, and it's powerful. But you see some people using some shoddy evidence for both sides. So let's get into that, man. The measure by which we measure the evidence. What is the hierarchy of evidence that you would propose we use to peck through data and to look through research?
Yeah, it's a great question, and there isn't a super simple answer. But basically, a randomized controlled trial is one of the highest levels of evidence. And then if you can do a systemic review of randomized controlled trials, so you can combine a whole bunch of randomized controlled trials, that's the top. Mm-hmm. So systemic review of RCTs, then RCTs. And then after that comes these prospective cohort studies and then the retrospective observational studies, which are much lower. And more importantly, though, you have to understand the strength of association, right? Because people say, look, observational studies are great. Epidemiological studies are great. Just look at smoking, right? You don't need a randomized controlled trial to prove smoking causes cancer. Agree with that completely. The risk ratio or the hazard ratio for that was 20, right? At 20 to 30 in that range. The ones we're talking about with nutritional epidemiology are 1.1 or 1.2 as opposed to 20, right? Those are completely different things. You cannot compare one to the other.
And there's ways that when you describe the numbers where you can make it seem in the average person's mind that this is an incredible increase in risk when really it's not such an increase in risk, right? Like the difference in risk from 0.1 to 0.2 is pretty big. If you frame it in a certain way, you can say there's a 100% risk increase. It's definitely, it's not so simple as the numbers that people put forth.
So that's when you talk about the relative risk reduction, the absolute risk reduction, and that's a big thing with cholesterol and statins that we can definitely get into. But so the hierarchy has to start with whether it's randomized, whether it's observational, and then you have to get into, who the patients were, the length of the trial, what was the intervention, and what was the outcome, what was the actual number. And, a lot of these reports say low carb diets increase the risk of dying, right? We had this sort of rash of those studies coming out months ago and last year. And, low carb was less than 40% of your calories from carbohydrates, right? Like, on what planet is that low carb? That just doesn't make sense to me. But also, there's this healthy user bias and confounding variables. So when the message that's being promoted in the doctor's office, on popular media, in every newspaper and magazine in the 80s and 90s and even early 2000s is fat is bad, fat is bad, fat is bad, then the people who are eating more fat are likely also not doing other healthy things for their body, which is a completely different story than sort of this new low-carb movement that is based on health, that is people looking to improve their health. That wasn't the case necessarily in the 80s and 90s. So you can't separate that out. So that sort of almost invalidates the majority of that data because if you dissect the data, you see the people who ate more red meat, saturated fats, whatever, were also heavier. They also smoked more. They also had more hypertension, right? And it wasn't that the red meat caused that. Yeah. It was the red meat doesn't cause you to smoke. It just shows the decisions that they're making. So these are the things that that enough people don't talk about, because again, it just comes down to evidence is evidence, and it's all the same, and that's definitely not the case.
So the healthy user bias, this is something that can be kind of difficult to account for, right? I mean, with most of these observational studies, with the population studies like this, how can you go around this? How can you make sure that you're not just feeding into this in your analysis?
Yeah, I mean, it's not just difficult to account for, it's impossible to account for. Like, how could you account for every decision that somebody makes during their day? So, how do you go around that? I mean, you really can't go around it. The studies that are these data mining studies, or these retrospective observational studies, they're all confounded by that. So one study tried to get around it and said, okay, let's look at people who shop at health food stores, and we'll compare vegetarians versus omnivores, and it was part of the study to see what their outcomes were, and there was no difference. Yeah. So by saying who shops at health food stores, you're pre-selecting your population, or they can do it for people who take vitamins. So you're trying to pre-select your population for people who are more thoughtful about their health, more concerned about their health. Is it perfect? No, but it's certainly a step in the right direction.
Well, I mean, how many people shop at health food stores in affluent areas because they feel guilty about being so overweight and so sick? So like, well, I'm going to Whole Foods to get my donuts, right? I mean, it's like you can kind of go either way with some of these things. Sure. And I guess demographics, right.
And that's why it's not perfect,
right? So then, geographic location and cultural differences are going to account for a big, sway in healthy user bias in either direction in a lot of these places.
Absolutely. So socioeconomic status, demographics, where you live, what your background is, your ethnicity, how you were raised, all these things play into it. And it's just not something that you can easily control for. So that's where the RCT comes from. You just get, a big selection of people, just random selection of people, and you randomize them to one way of eating or the other. And then you follow them. So you're taking out that user bias, but those are incredibly difficult studies to do. They're very expensive, and not many people are going to want to sign up for it. Mm-hmm. Would you sign up for something where we're going to tell you what to eat for the next year, and you have to eat that? You don't get to choose what you're going to eat. Right. I wouldn't do that, because I eat the way I want to eat. So it really it's sort of, I mean, I'm painting a very depressing picture, right? I'm painting this picture where the science, nutritional science, is really poor and makes it difficult to reach conclusions, which, going back to the 70s, where these conclusions were made that this is the one healthy way for everybody to eat, it was based on a house of cards. It was based on science that was not meant to have that level of certainty.
Yeah. No, it's a difficult one to account for. So randomized controlled trials, and then meta-analyses. I mean, what kind of limitations do we have when we're looking at meta-analysis in general? I mean, you mentioned healthy user bias, but are there any other factors that might come into play that might make these a little bit more difficult to assess and discern if they're good studies, bad studies?
Well, so what's interesting about meta-analysis, so it's a combination of a whole bunch of different studies to try and increase the statistical power of it, right? Because if you do a study that's got 100 people in it, you're not going to be able to show much of a difference. But if you combine 1,000 of those studies, all of a sudden you've got enough people that you can show a difference. That's an extreme example, but you get the point. So the problem is, though, if you're starting with low quality observational studies with healthy user bias and confounding variables, and you combine a whole bunch of them, you're not making it any stronger. You're actually just amplifying the noise. You're amplifying right. the same biases and the same problems. So that's the problem with meta-analyses of observational studies. You're still limited by the weakness of the original data. And then what's fascinating is you see meta-analyses that say clearly saturated fat causes heart disease, and you see meta-analyses that say clearly saturated fat does not cause heart disease. Yeah. So a lot has to do with the studies that you pick, right? I mean, you can set up your criteria for picking studies however you want, as long as you can justify the decisions you're making. But there are plenty of meta-analyses and plenty of observational and epidemiological studies that show no association between saturated fat and heart disease. Yeah. So why is it then proven that it does? It just doesn't make sense.
Man, yeah, no, it's funny because no matter how good the science is, no matter well designed studies are, we're ultimately limited by, in the paradigm of the scientific worldview, you always have to deal with the subjective nature of your experience within the supposedly objective framework of analysis, the scientific method. Like we're still so limited by subjectivity. It's kind of a philosophical.
Right. So at dietdoctor.com, we include a number of anecdotal reports, patient experiences. We include clinician experience as part of our evidence basing now, but it's a very low level of evidence basing because it's not, it's not scientific, it's not peer reviewed and all those things. So it's the lowest level of evidence, but it's not that you should ignore it just because it's the lowest level. You still include it. You just have to put it into perspective. And that's the thing as a clinician, sort of stepping outside of my evidence basing role into my clinician, just helping one person. When you see the power of it helping somebody, that's hard to turn away from. Now you want 20-year evidence to say it's safe and is going to make everything better and make the roses smell better, but we don't have that data, so we have to do the best with what we can. It's just, do you see things from a broader perspective, or do you kind of keep your nose in the books and everything that you were taught is all that you believe, and you can't sort of broaden your perspective from that? That's sort of the shift I've seen personally and in a number of physicians who are now using low carb to help their patients.
Yeah. So when you became a physician, you became a cardiologist. What sort of practice were you working in? I mean, you see people who just had heart attacks. Are you looking at more general population, looking at preventative medicine? How was this when you started out? Like when you first got into it?
Yeah, so I did a preventive and general cardiology fellowship. So my focus I always wanted my focus to be prevention. But then my main job was a general cardiology job. So, in the cath lab, seeing people with heart attacks, in the ICU, rounding on people in the hospital. And then also with an office practice, trying to focus on prevention. But, I got to be honest, our medical society is not structured for prevention. Yeah. It doesn't pay the bills. It doesn't, the focus of the practice was, more on the inpatient side, more on putting in stents, more on, doing valves, taking care of patients, doing it hopefully appropriately, but that's sort of more of the focus rather than the prevention. And that was a frustrating part for me, that I wasn't doing the amount of prevention that I wanted to be doing, which is why I started my own wellness center to try and focus on the prevention. That's why I'm now doing telemedicine consults, focusing on preventive cardiology. And why I'm working with Diet Doctor as their medical director, because that's how you can reach millions of people, right? I can help one person one-on-one, but if you can get the information out there in a way that's making it simple, making it easy to digest, and is reliable and is going to help them, you can help millions of people. So it's kind of changing the forum for how we help people a little bit.
Yeah. Then the low carb diet came into your practice, and you started implementing it with patients. What sort of results did you see that actually impressed you?
Well, so a couple things. One is the results of people losing weight, people improving their health markers like their blood sugars and their hemoglobin A1C and their inflammatory markers and their HDL and triglycerides. All those things improve. But what really did it, those things are important. But what really did it was people saying wow, this is the first diet I've been able to stick with. This is the first plan that's been easy and I enjoy. I don't think about food all the time. I'm not worried about what I'm going to cook. I'm not hungry and snacking. If I leave the house without my snacks, I'm not in big trouble, right? That's that's the low fat, eat less, move more kind of mantra that just makes us constantly hungry and constantly thinking about food. And this new approach, and I never thought about that before, right? There was always I hate to admit it, but it's so rampant in medicine, the non-compliant patient. Patient was non-compliant with the lifestyle. And it's like our defense mechanism. It's not my fault. It's not that I'm recommending the wrong thing. It's your fault that you couldn't stick with it.
Yeah.
But now all of a sudden it was like, oh my God, I've just been recommending the wrong thing. That's why people couldn't stick with it. And here's something that people are sticking with and really enjoying. Now, nothing's 100% right. There's some people who are like, oh, that was so much fat. I couldn't eat that much fat. I don't feel good on that much fat. And then you alter it and you make changes. But the vast majority of the people are like, wow, this is easy. This is great.
So in the
And
general,
that's what I really.
yeah. So you're seeing a lot of obesity, right? You're seeing probably a lot of diabetes.
Yep. I see a
And
lot of diabetes and heart disease and dyslipidemia, and obesity is certainly part of that. Yeah.
because it's so interesting, because diabetes tends to correlate, or the insulin resistance seems to correlate highly with cardiovascular disease, but
Sure.
high LDL cholesterol does not correlate highly with diabetes and obesity necessarily. So I mean,
Right.
it's kind of an interesting paradox there. Now, and I'm
Sure.
sure when you first started out, you mentioned all those health markers improving, right? HDL to triglyceride ratio being something I find that a lot of people look into, and I'm sure you've heard of Dave Feldman. He's done a really good job of showing. There you go. So yeah, Dave, you've done a great job, man. I think everybody's pretty impressed with the work you've done in the last few years in this space. But you mentioned,
amazing.
yeah,
Right.
hemoglobin A1C getting better. The inflammatory markers getting significantly better. But what was happening with LDL? Because this is one of the most interesting paradoxes of the low carb world that really freaks a lot of people
Yeah.
out. And this cuts right to the core of the lipid hypothesis. The heart disease equals high cholesterol in your blood, and they're one
Right.
and the same thing.
Right.
Yeah, what were you seeing with the LDL number?
Yeah. So for the vast majority of people, nothing, no difference. And that's what the studies support as well. When you're looking at patients who are overweight or with diabetes and you treat them with a low carb diet, the majority of them, their LDL-P, their particle number, or their ApoB does not go up for the majority of people. In fact, their LDL size gets bigger. You get less small, dense LDLs. And then the HDL goes up, the triglycerides go down. It's a more favorable overall lipid profile. That's for, I don't know, probably 70% of the people that you see. And then there is a subset where the LDL goes up. And in the beginning, it was like, oh my God, what does this mean? What do we do about this? This looks scary. But now learning more, look, LDL is an important cardiovascular risk factor. Yeah, I would never argue that. Is it the most important? I think there's a debate there, but it's clearly a cardiovascular risk factor. But it's the same sort of thing. Do we just accept that on face value, or do we try and learn more about it and go deeper?
Yeah.
Oxidized LDL is worse than non-oxidized LDL. Small dense LDL is worse than the larger LDL. It doesn't mean the non-oxidized larger LDL is no concern at all, but it certainly means it's less of a concern.
And how did we come to this conclusion? How was this conclusion reached that, that everybody was so sure that LDL was a cardiovascular risk factor?
Well, it goes back to the sort of the Framingham risk, the Framingham study, and then the Framingham offspring study, and then the Mr. Fit trial. These epidemiological studies where you just follow people over years, decades, and see who lives, who dies, who has heart attacks, who doesn't, and then you sort of crunch the data to see what was the risk factor. And the LDL curve is like this: the higher the LDL, the higher the risk. It's fairly linear. And then you look at what they call Mendelian randomization studies, or the genetic studies. So people who have familial hypercholesterolemia, where your LDL is high, where you either have a defect where you basically have a defect in the LDL receptor. And they have a higher risk of cardiovascular disease. So therefore, that's more evidence. And then there's the drug treatment trials where you use statins or fibrates or other medications. Now it's all about statins and PCSK9 inhibitors to lower LDL, and you lower the cardiovascular risk. So combining these three fields of studies, the epidemiology, the genetic studies, and the drug intervention studies, there is a wealth of evidence that LDL is related to cardiovascular disease.
Now, I got a question just about the last method of evidence that they use. So the I'm sorry, I lost my thought there. Can you remind me of what the last one was? The last point you made?
The drug treatment with
drug treatment. All right, so drug treatment with statins. You mentioned it lowers your cardiovascular risk, your cardiovascular disease risk. How do we determine cardiovascular disease risk?
Well, I should say cardiovascular outcomes. So most of the studies did look at outcomes, so heart attacks or strokes or need for revascularization.
So after the first heart attack, statin drug interventions seem to lower the recurrence of another heart attack, right? Right. Okay. And
for some high risk primary prevention, it can lower your risk.
Yeah.
But next comes though the nuance, which frequently isn't talked about, and that's the degree of benefit, and also what else is going on. Because if if you're lowering your risk of heart attack, but not changing your risk of dying, then what else is going on, right? Because statins increase the risk of diabetes, they increase your risk of intracranial hemorrhage, and these are small, right? I don't want to make it sound like everybody who takes the drug gets these problems, but these are small risks. But if the benefit is also really small, then you have to counterbalance it. So it's, the higher your risk, the more likely you are to benefit from statins, and the lower your risk, the less likely you are to benefit. But the other part of it is when you're looking at LDL, I was talking about how oxidized is worse than not oxidized, small dense is worse than not small dense.
Yeah.
If you break down the studies and control for metabolic health or for HDL and triglycerides, the risk for LDL either goes away or is dramatically lower. Yeah. So again, it's understanding the nuance and putting it in the context of the patient, because that's what we're dealing with. We're dealing with one patient. I'm not dealing with a whole population of 10 million people. I'm dealing with one patient in front of me. So my job is to find out what's the right approach for that one person, and what does this LDL mean for this one person in context to their whole health profile. And that's where it gets interesting, right? That's where you can really start to impact people, rather than, here's your one lab value, here's your drug to treat that lab value. Well, what are we really treating? Are we treating a lab value, or are we trying to improve their overall risk profile?
Yeah. Yeah, that's a really good way of putting it. Because, I see a lot of people who, people come to me for coaching who've been doing great, but they get a little bit freaked out by the LDL number, right? That's always something that's, it's like everything looks great. My whole blood panel looks fantastic, except my LDL increased, right? Now, their triglycerides usually dropped significantly. Sometimes they're cut in half, or sometimes they're 30% of what they were. It's pretty crazy. HDL tends to go up, sometimes, doubling or tripling. And then the LDL also goes up, and everything else looks better. Like, we're talking about people who maybe had, chronic inflammatory conditions, and their CRP has gone from 7 down to, 1. And so you see all these other improvements, and then LDL goes up, and the doctor's like, we should really get you on a statin. And, so some of these people, they don't know what to do. But then what becomes interesting also is when you look at things like coronary artery calcium exams too. So are you using that as a tool frequently as well? I know a lot of the plant-based doctors agree that this is one of the best measures of risk for cardiovascular events.
Absolutely. I'm a big fan of calcium scores. Because it can help refine your risk so much better, pretty much, than anything else. And there's studies showing that if a calcium score of 0, then statin therapy over 10 years really has no benefit, in that one study out of Walter Reed. So I'm not the type of person who says LDL is meaningless, and if you have high LDL, you're going to do better and live longer. Although there's some small observational studies to suggest that. I don't promote that on an individual basis. I promote digging deeper, and calcium score is a great way to dig deeper, to learn more about the person, and follow it over time, right? Like, we don't know that hyper responders with high HDL that are high LDL that are large LDL and not oxidized, and everything else looks perfect. We don't know that they're going to do great for 20 years, right? There's reason to believe it, but we don't know. So one option, if you work with your doctor to come to this agreement, is we follow you over time with calcium scores, with carotid intima media thickness tests, looking for any signs of atherosclerotic disease. Because if it's there, we want to know, right? We don't want to turn a blind eye to this and assume it's going to be fine.
Yeah.
But we don't want to assume it's going to be dangerous either, necessarily.
Yeah, that's a really good way of going. You don't want to swing the opposite direction and not be worried, because it's about context, right? And there's so many different things that are affecting how the organism is functioning in the environment it's in. And there could be environmental factors beyond just your dietary saturated fat intake. And it seems to me like the seed oils, the polyunsaturated fats, seem to present a much greater risk than your total cholesterol level, and these fats tend to drop cholesterol levels, drop LDL levels, but we also see some evidence suggesting that they're involved in this. What do you think about polyunsaturated fatty acids, omega-6 fatty acids, corn oil, seed oil, as far as heart health goes?
Yeah, it's a good question. And my gut says they're awful, they're terrible, stay away from them. They're made in factories. You need high heat and chemicals to extract the oils. And all that just sounds terrible. There's not great evidence, to be honest, to say they're bad for us. There's that one study, the Minnesota coronary experiment, where people had the higher amount of polyunsaturated fatty acids did worse. The Sydney heart diet study showed higher level of poly, and PUFAs also did not do any better. So there's enough there to kind of make us think about it, that just because an oil lowers LDL does not by default make it healthy. And I think that's sort of the problem we run into. But we also have to keep an open mind.
If something were to lower LDL but cause an inflammatory response and cause systemic inflammation, which it seems to me like there's a really good case to be made that these seed oils do cause chronic inflammation. We know high omega-6 levels in the diet, not such a good idea. Even in the plant-based population, they're trying to kind of cover their bases in different ways there. So, it's really interesting. But you're not so convinced that they're generally bad, though, the seed oils?
Well, I'm not convinced that the literature and the evidence supports it. Right. I tell my patients to try and avoid them. If they said, what is your evidence for that? I would be perfectly honest and say, look, there's some trials like this Minnesota coronary experiment. There's some mechanistic and theoretical reasons why it is. There's, evidence from my own practice and patients I've seen, but I can't point to some great study to show that they are harmful for the long run. So I believe in being honest about that.
But do you think that this is an example of like how maybe, how sometimes the hierarchy of evidence can't be applied as a dogma? The hierarchy of evidence would push away a lot of mechanistic evidence, right? But also this mechanistic evidence could be systematically eliminated from analysis using meta-analyses and stuff like that. And there can be so many healthy user biases and so many confounding factors that might make it to where that's completely invisible to the researcher who's looking at it from another angle.
Absolutely. I think that's a great point. Yeah, really good point.
It's kind of freaky, though. That's like, okay, well then, we've got to go by, we have to sometimes use anecdote before a randomized controlled trial in certain situations, it seems.
Yeah. I mean, you look at someone like Tucker Goodrich. He is like the amazing anecdote for omega-6s, how he has transformed his life by avoiding omega-6s. And I think he's even done some experiments where he tried it again and felt awful. And so for him, it's clear, right? And I had a podcast episode with him actually like a couple of years ago, I think at this point. It's almost like he was lucky that he had such a profound response to it, because he could know, right, like that. Most people aren't going to have a response like that. So if it is slowly causing some problems, they're not going to feel it or they're not going to know it. But we also don't have, evidence to prove that. But like I said, in a situation like that, I still tell people to avoid it because they don't need it. Like, why do you need an oil made in a factory that uses heat and chemicals to extract it when you can just go eat food?
Right. You can go eat a steak and you can get a lot of good monounsaturated, saturated fat there. I mean, I'd rather people eat a steak than have coconut oil most of the time. And,
nuts and fish and, get a wide variety of different types of fats and avocados and olives and then steak and chicken and, you're eating real foods and getting plenty of fats that you don't need these industrial products.
Yeah, well said. Yeah. Well said. Yeah, so the hierarchy of evidence, I mean, it's so helpful, but I love how you take a nuanced approach to it and are not just, trying to apply a transparency over every single situation and, connect the dots using that. I mean, sometimes we got to think on our feet a little bit and analyze the situation. So
we're big proponents of eating nose to tail. Whether you're on a ketogenic diet or a carnivorous diet, or a diet that focuses heavily on animal foods but still includes some carbohydrates for performance, we are big proponents of eating nose to tail, using the whole animal. And that's why we included an entire section on how to prepare nutrient-dense organs, nose to tail, in the Carnivore Cookbook, 0-carb recipes for people who really love animals, which you can find at primaledgehealth.com. Today's episode is brought to you in part by Ancestral Supplements, putting back in what the modern world has left out. Ancestral Supplements brings you nose-to-tail organ meats like liver, kidney, pancreas, brain, marrow, heart, thymus, thyroid, and more in simple, convenient gel and capsules. We know that a lot of people are trying to include more organs in the diet. A lot of people are trying to focus on the deep nutritional benefits that we get from eating nose-to-tail, and it can be a little bit overwhelming when you're first starting out. If you're unable to source these things, if you travel a lot and want something that you can bring with you to make sure that you're covering all your nutritional needs on the road, Ancestral Supplements offers liver, kidney, pancreas, brain, bone marrow, and more in simple, convenient gelatin capsules. We often recommend Ancestral Supplements to our clients in the Keto and Carnivore Collective, our monthly community coaching course to help you dial in your diet and lifestyle so that you can live optimally. They're called Ancestral Supplements, but these are really whole, unrefined foods. Dried, grass-fed, grass-finished beef organs in convenient gelatin capsules for you and your family. How often do you use statins in your practice, and what do you see their function within your practice as?
Yeah, it's kind of funny when I go to cardiology meetings or lipidology meetings. I'm the statin opponent, and when I go to low carb meetings, I'm the statin proponent. So it just depends on the audience you're hanging out with. So yeah, I mean, I definitely use statins for secondary prevention. It is one of the most effective medications we have. Doesn't mean it's the most effective treatment, but it's one of the most effective medications we have for reducing cardiovascular risk. So if you've already had a heart attack or a stroke or a stent or bypass surgery, you sort of have identified yourself that is your highest risk, that is, you've already proven that that's a risk for you. So being as aggressive as you possibly can to try and reduce that next risk involves a statin. Now, there are different ways to do it, right? Because every medication has potential side effects. So you want to use a medication in an intelligent way to try and reduce the risk of both short-term and long-term side effects and to make sure you're getting the benefit. Yeah. Now, the harder question is for primary prevention. And this is where I really sort of wrestle with people in the lipidology community. There's this impression of sort of like almost a shotgun approach. Like we don't want to miss the one person who's going to benefit from a statin. So let's give it to a whole wide swath of people to make sure we're going to capture everybody who could benefit. And if the side effects were making you feel better and making you exercise more and making you live longer and making you think better, if those were the side effects of the medications, you could say, okay, that's a reasonable approach. But it's not. The medications have potential side effects. So I think we need to be smarter about identifying the higher risk population for primary prevention. That's where calcium scores can really play into things. That's where, using lifestyle to try and improve someone's baseline health can really play into something before reaching for the prescription pad. And that's where I think we need to tease things out a little bit better.
Yeah. So what are some of the side effects of statins that you see as more prominent? And do you see the research on statin side effects reflecting the actual results you see in your patients as far as the side effects go?
Yeah, well, and this is again where you have to understand how trials are conducted. Because if you look at most of the statin research, they say there's less than 1% risk of side effects. Well, that's, a trial funded by pharma, right? Designed to basically maximize benefit and minimize side effects because they have a run-in period. They give everybody the drug for a couple of weeks in the run-in period, and anybody who has side effects, they exclude from the trial. So you're not getting a real-world population. But then when you look at some of these registries and more real-world studies, even though they're not RCTs, they suggest anywhere from 20 to some studies like 50%, which I think is too high. Yeah. But my guess is it's around 20% who are going to get muscle aches.
It's a lot too. I mean, that's like two out of 10 people who are going to get muscle aches. And shoot, I mean, if you've got, I'm thinking of my friend, just the one example that's fresh in my mind. He had real bowed legs. He had knee injuries. He had really bad posture and stuff. This poor guy must have been in a lot more pain afterwards because, yeah, I mean, it's crazy. Yeah. It seems like that type of population would respond more with that sort of side effect too, right?
Yeah. So one argument though is, look, muscle aches versus a heart attack. Which are you going to do? Which are you going to choose? Yeah. But if the muscle aches are enough to affect your lifestyle, so now you're not exercising, you're sitting on the couch more, you're grumpy because you don't feel well, no one likes to be in pain. It goes way beyond just a muscle ache. I mean, it can be life-changing for some people. So you really need to pay attention to it. Yeah. But then the ones, that people are more concerned about are making diabetes more common. So, absolutely. That's why when I do treat someone with a statin, I like to treat them with a low-carb diet because you're improving the insulin sensitivity. You're reducing the risk of diabetes with the low-carb diet to counteract the potential increase with a statin. And then the big one that most people are concerned about that we have the least amount of evidence for is the cognitive decline. And that's such a hard one because when you're talking about people in their 70s and 80s, there is some cognitive decline that happens there anyway. So trying to say, is it from the drug? Is it not from the drug? Is a little bit more difficult. But I mean, even the PCSK9 inhibitors, there was this meta-analysis of sort of all the PCSK9 inhibitors. And some of the studies were 6 months long and showed really no difference in cognitive decline. But then the ones that were out to a year actually showed a difference in cognitive decline in only 1 or 2 years. And that's, that is concerning.
Yeah.
So, LDL has a role. We need LDLs in our brains and our neurons. So, it's not very common, but it certainly is enough of a concern. And a lot of people would rather keep their marbles than worry about, reducing their risk of a heart attack by 1%. So it's something you have to balance. It's not easy to do, especially when there isn't robust evidence to point to, but yet is someone's highest concern, right? So that's part of the art of medicine, I guess.
Yeah. And you mentioned how difficult it is to tell if it would have happened anyways, if you would have seen this cognitive decline, regardless of if the statin intervention happened or not.
Right.
But then again, you always wonder too. You always wonder how much of this is the drug and how much of it isn't. It's a hard decision to make. It's like a Faustian bargain when you get on these things almost.
Yeah, good reference. Yeah. So, and that's part of weighing the different risks and patients' concerns. If someone comes to me and is like, look, everybody in my family has died of Alzheimer's disease. I've seen it happen in front of me. It's the most miserable thing in the world. I'd rather go any other way other than that. Okay, that's pretty powerful. Versus somebody who says, like, everybody in my family dies of heart disease. I've already had a stent. I know that's going to be my biggest health problem, and I want to address it as aggressively as possible. Those are the easy ones, right? Those are the easy ones to decide drug treatment or not drug treatment for cholesterol. But it's the people who are in the middle who are a little bit more difficult to decide on that you have to sort of come to an individual agreement with what their concerns are and how they want to approach it.
Yeah. I'm kind of trying to imagine what your population of your clients looks like. I mean, have you seen a difference in the population of your clients since going towards a more low-carb approach? Do you find...
Definitely. Yeah, now people come to me because they don't want statins. They want to come off their statins.
Yeah.
And, there are a number of them who I say, look, you know what? I know that's what you want to hear, but I don't think that's the right case for you. Because people who have a high LDL on low carb, they want to believe that they're this lean mass hyper responder that Dave Feldman talks so much about. But if your calcium score is 300, if you've already had a stent, if your triglycerides are still 200, if your A1C is still elevated, or you have small dense LDL, then no, you don't fit the hyper responder profile perfectly. So we have to treat you a little bit differently than that. And so I have a number of patients that I work with on that I do use statins. I do use PCSK9 inhibitors in the right situation. Yeah. So
it's all about context.
Yeah, absolutely. Absolutely.
Yeah. The ketogenic diet, the low carbohydrate diet, what do you think it is about it that makes it so much easier for patients and for people who are trying to lose weight and trying to manage their cardiovascular risk factors? Why is it easier than eat less, move more? What's so special about it?
Yeah, I mean, because you feel full, you enjoy your meals, and you can, the concept of time-restricted eating 2 meals a day or even 1 meal a day, that was something I never heard of, pushing the low-fat diet. But now, when you don't have to worry about, shopping and preparing food and worrying about what you're going to eat, it just makes it so much easier to stick with. And you feel full, you feel well, you have a constant level of energy rather than getting like the glucose swings and the post-meal like drowsiness and things like that.
Yeah.
Like they just feel better on a higher fat, low carb diet. And that just makes it so much easier to comply with and to live your life with. Yeah. Now, the hard part is, we're still in a carb-centric society. It's still everywhere around us. And, people still have this concept like, what's the big deal? It's just like a bowl of ice cream. What's the big deal? It's just some cookies and cake. What's the big deal? It's just a birthday party. But it happens time and time and time again. And it is a big deal, especially if you're sensitive to carbs and insulin resistant. And it's a big deal.
Yeah.
Yeah.
What about, you've seen like the rise in popularity of ketogenic diets the last few years, and that's brought along with it these pesky little carnivore diet folk. So I've definitely enjoyed a lot of benefits of the reduction of vegetables. It definitely was against what I would have expected, but I've found that using less vegetables for me tends to be a net benefit, and a lot of people like me out there end up finding that their ketogenic diet improves when they go more carnivorous. What do you think about this, and have you explored much of this in your life or just personally?
Yeah, so no, not personally, I haven't, because I'm one of those people who loves vegetables and does very well with vegetables.
Yeah.
But, I've talked to a number of people who are carnivore and seen the transformation they've had. They have this incredible transformation just going from their standard diet to a low carb or keto diet, but then still aren't getting kind of all the results they want, then go carnivore and have that same almost level of transformation with carnivore. And it's fascinating for me. Like, I still sort of wrestle with it internally, but I understand, like, if you were improving your life and you're feeling that much better, of course you should do it. Like, I wouldn't change that. Now, just like anything, whether you're doing keto or whether you're doing vegan or whatever, you still follow your labs and your health markers and how you're doing. You don't just close your eyes to it no matter what. But I think it's amazing the way it's impacting people's lives. So absolutely. I mean, I definitely use it in some of my patients. And I believe it has its place. Absolutely.
Yeah, even low oxalate diets seem to have a really, really powerful effect. Even outside of keto, some people don't want to go full keto. They still like some fruit and vegetables, but keeping low oxalate seems to be really, really powerful in certain cases too. So yeah, the nuanced approach, it's all really about the context of the individual. What about low carbohydrate diets, lower carbohydrate diets that are not ketogenic? Just decreasing carbohydrate intake, eating some fruit, but eating mostly filling up on fats and proteins. Do you think that this middle ground type diet, a more balanced kind of a paleo approach, has its place?
Sure. Absolutely has its place. If you are trying to absolutely treat diabetes, you're trying to treat metabolic syndrome, you're obese and you want to lose weight in the best approach possible, keto is likely going to give you more benefit than a more moderate low carb. And so how do you define moderate low carb? Is it 50 grams of carbs? Is it 100 grams of carbs? Well, all those are low carb compared to the 200 to 400 average of what most people are eating, depending on the study. But so I think the more aggressive you are, the more likely you are to get more dramatic benefits. But there's still people who become more insulin sensitive, or people who aren't as insulin resistant to begin with, can certainly benefit from the more moderate low carb diet and still do very well with it, even if they don't go full keto. I think that's perfectly reasonable. And then if you can factor in time restricted eating or intermittent fasting with that, short-term intermittent fasting with that as well, you're going to get even more benefit. And I think that should be a part of people's lifestyle, no matter what you're eating. This concept of 6 meals a day, constantly keeping your nutrient sensors stimulated and constantly having your insulin levels high, just doesn't make sense anymore. So no matter what you're eating, you're factoring in the time restricted eating, I think is crucial.
That's a really good point. What about extended fasting? What about fasting a little bit more than the intermittent fasting window?
Yeah, I'm torn with extended fasting. I think it can have its place. I don't use more than like a 3 or 5 day fast, hardly in anybody. And even the 3 and 5 day, I think has some probable longevity benefits, done on a quarterly basis or twice a year or something like that. Otherwise, I use more like maybe 24-hour fasts a couple times a week. But everybody's a little bit different depending on what your goals are and what you want to get out of it. Do you want longevity? Do you want weight loss? And you have to do it in a way where you're not going to wreck your metabolic rate, your whole metabolic function, because these chronic calorie restrictions or these long-term fastings are definitely going to upset your basal metabolic rate. And over the long run, I'm not sure that's going to be all that beneficial. But the shorter term, intermittent, I'm pretty convinced that's going to be a long-term benefit. Yeah,
good point. Yeah, I think with the long-term fasting too, I mean, it could become a disorder. You've got anorexia nervosa, which is, it's a fasting, it's a fasting induced, or not induced, but it's a disorder around fasting and not eating. So I think some people can use it as a way to justify kind of some weird eating patterns. So.
Yeah, I mean, we have to be honest, right? A lot of people have a complicated relationship with food, and it's emotional, and they've got a history of, whether it's a history of their relationship being very different than it is now, that fasting can sort of bring some of that out and can bring up some complicated issues. So you have to get into the psychology of it with patients as well to make sure that they're okay for it.
Yeah, I think you see a lot of people with the juice fasting kind of go a little nuts with it. I don't know. Especially on the internet, people start getting into juice fasting, and it's it's a slippery slope with some of that.
Yeah.
You feel so good. Like some people, they get like a high from fasting almost. They get hooked on it.
Right, because they're getting into ketosis, right?
Yeah.
They're getting into a deeper level of ketosis just by reducing their calories. You can get that even if you're having carbs coming in. If you're only having 400 calories or whatever, even if it's carbs, chances are you're still going to get into some degree of ketosis. It's just more of a starvation ketosis than a nutritional ketosis. But you got the ketone bodies. If your brain likes them, if you're one of those people who gets like that buzz or that increased cognitive function on ketosis, you're going to feel that.
That's funny. Some people do, some don't. Some people,
Yeah,
the people
right.
who do, they love it. They get stoked. And then some people, they feel a little bit better. They like that they don't need to eat so much. But they're like, I feel more or less the same mentally and cognitively.
Right.
And then some people, it's
Right.
like a light turned on in my head and my depression left. And it's, it's totally, it's funny. So yeah, the own individual experience seems to be so different and varying across populations.
Yeah. Yeah, I think that's true. There was a time where I was sort of using exogenous ketones in some people. I don't really use it very much anymore, but I remember this one person I gave it to. She was buzzing. She was like, "Wow, this is amazing. I feel so different." And then use the exact same exogenous ketone with somebody else, and like, I don't notice much of a difference, but it's dramatic, the change that people can see, and it's sort of the same thing with fasting or deeper levels of ketosis, nutritional or starvation ketosis.
Yeah. Now, what about for do you see a lot of fit people? Do you see a lot of people who are in shape? Do you get athletes as clients sometimes, or do you see more overweight?
Oh no, I definitely see a whole spectrum. I see a lot of people who are fit and trying to do this for longevity, right? They're not trying to treat obesity or diabetes or metabolic disease. They want to give themselves the best shot of longevity, and they want to feel as good as they can. And some people want to improve their athletic performance. So I see a whole swath of people like that as well. And it's impressive that the improvements they can get. Now, a lot of these people are the same people who are going to have high LDLs as well, interestingly. So I see a lot of them for that reason too. But it can definitely work for athletic performance. Usually performance goes down before it comes up when you start a low carb keto diet, but and it depends if you're, an endurance athlete, if you're a high glycolytic type athlete, it makes a difference. I had a podcast with Rob Wolf. He was on my podcast and he mentioned he'd broken many a jiu-jitsu athlete with low carb.
Yeah, exactly. With those people, I usually tell them have more carbohydrates, right? I mean, it's
right.
And they can handle more and still be in ketosis too. I mean, sometimes just some carbs around training, like, hey, have one piece of fruit before you train, or have a little bit of honey and fruit before you train, small amount, and then after that they're back in ketosis anyways. So I think that's an interesting population to work with, because that's the one I find, as far as athletic performance, they feel very acutely the dip in performance when they first start out. And it can be hard for them to stick with that for more than a few weeks. If it's like, if 2 weeks later they're just still not feeling it and they're still not as strong, it can be hard to convince them to move forward with it. So sometimes a more moderate carb approach in some of those cases is better, just because they don't have the time or the desire to spend 3 months with low performance.
Right. And I don't think anybody has more experience with this than Doctors Finney and Volek. This is sort of their wheelhouse, and they've said sometimes 6 months to a year. I think they've said, but what athlete is going to be patient enough for that?
Yeah, I never tell people that. I'm like, look, you're looking at a few weeks, because no one's going to stick through 6 months to a year. It's like, if you're not feeling it in 4 weeks, maybe you want to try something else, and we go in a different direction, because it's Yeah, and that's I find the population, like more sedentary people looking to lose body fat, maybe work out in the gym 2-3 times a week, they're good. Like their strength doesn't really tend to take a hit. But if you're looking at somebody who's maybe playing you mentioned combat athletes and stuff, the boxer or something, it's like, no, maybe have 100 grams of carbs and see how you feel from there. That's what I tend to do.
Right. And personally, my mountain bike days tend to be sort of my more intense workouts, a little bit longer and more intense than just my gym session. So on some of those days, I may have a few more carbs in the morning. But the other days I won't, so it's also knowing yourself. And, look, I don't get paid by my athletic performance, but it still feels pretty good to kick my buddy's butt going up the hill,
Yeah, very few people are ever going to get paid for their athletic performance, right? I mean, such a small percentage of the population, but it's fun enough to, the diet definitely affects it quite a bit.
Yeah, it's true.
Awesome. So, what state do you actually practice in? I forgot to ask you that in the beginning. Where are you?
Well, so I mean, I'm in California, but I have a telemedicine practice, and I'm licensed in California, Colorado, Utah, Arizona, Ohio, Illinois. So, I have a bunch of different licenses, so I can see people in different states. That's the beauty of telemedicine. But I'm actually physically in California.
That's great. Yeah, I think that's such an important thing, especially right now with the internet. I mean, it seems. How much has that changed your practice? Did you start out doing telemedicine consultation, or how did you get into that?
Yeah, I actually started out by just doing health coaching consults, because people, so many people are like, I can't find a doctor near me who is going to listen and is going to be open to low carb at all. So people just wanted help with their lifestyle. So I started doing that. But then realized I actually want to be their doctors. I actually want to help them as their doctor, not just a coach. Yeah. And so I ran around to get different licenses in different states and started this telemedicine practice. So it's not something I've been doing for a long time, but it's something that is, excuse me.
Cholesterol, man.
Choke here.
Cholesterol. You're choking on cholesterol's clogging up the lungs.
I was getting so excited talking about this, like all worked up here, because it is something that I really appreciate when people say, like, I just can't find a doctor to work with.
Right.
Who's going to listen to me and take the time and really factor this in. So to be able to play that role for people, I really enjoy. Excuse me.
Yeah. Well, I mean, I'm just thinking of somebody. I mean, it's like you go to a doctor or somebody, you go to somebody who even like a coach. It's so difficult to give even enough context sometimes, right? So especially as somebody, there are probably a lot of people out there who've been tracking their biomarkers, tracking their health, changing diet, changing lifestyle, watching their performance for years, right? I mean, it's like just like the athlete angle, the athletic angle. I mean, to switch coaches, I mean, it can take a long time before they actually figure out how to coach a certain athlete. I mean, coaching. Yeah. If you've got many of them all the time. So I think, it can be difficult for some of these people to find a doctor where they feel like they're listening to them, or that they even care, and that they're not just looking at them as a piece of paper and as numbers on a piece of paper to treat.
Right. So, yeah, I sort of look at my approach to medicine now in sort of two main ways: helping the masses and then helping the individuals. So helping the masses is with Diet Doctor and dietdoctor.com, and really getting the information out there to the individuals and to other physicians. And I think that's going to be a key part of our mission. Yeah. But then helping people one-on-one through the telemedicine practice to try and really impact people's lives and spend an hour and a half with them, whatever it takes, not the 5 minutes you're going to get at your doctor's office, but really impact their life in a more meaningful way. So I like the combination of helping the masses and helping the individuals. I think it's an important way to try and impact people's lives.
Yeah, right on. All right, so Dr. Bret Scher, I really appreciate you coming on. Really appreciate the nice, nuanced conversation we had. Where can people find more information? Where can people find your work?
Well, most of my work now, what I'm writing and editing and publishing is at dietdoctor.com as their medical director. That is the sort of the best site to go to find my opinions on things and what I'm writing, and to find the most evidence-based low-carb information out there. To find out more about my practice, it's lowcarbcardiologist.com, and happy to help people however I can.
All right. Dr. Bret Scher, really appreciate you coming on. You guys can find more at primaledgehealth.com, and we'll see you guys next time. See you later, Bret.
Thanks a lot.